so we have consensus. So, yeah, so at the next meeting, we're going to need to vote on both the written minutes from the last meeting and for this meeting, because the minutes that we have for the last meeting are the electronic minutes. Obviously, we can go back and re-archive those. So we won't have a vote on agenda item B today because we need to get the written minutes from the program. And then we'll have both sets of minutes from last time and this time. Go ahead. Did everyone explain how the mics work? Do you keep pressing the button when the green light goes off and all that kind of stuff?
I didn't know that.
Okay, so the green light's on, and that means the mic is on.
Okay.
If you want to turn it off, there's a button that says mute on the left, and don't just push it a little, you have to hold it down. Eventually it turns off. And so that's how the mics work, and it would be great if we could continue to move that, because like I said, we're on the live stream. So let's go on to agenda item C, and we've got presentation on the Washington Smooth Transition Model. So you've got a PowerPoint, and so why don't you take it away.
I'd like to thank the committee for think ACHDS, and then also for allowing Wendy and I to speak to this issue. So this is transport safety relevant to home birth and the providers that give maternity care. I think we could all agree that pregnancy, delivery, and postpartum period is and the safety of the mother and infant is our primary outcome goal. All right, how about that? All right. So informed decision making. I'm going to present ACOX. Supports informed decision making by women about their care options. As physicians, we inform patients. We inform, educate, and respect our patients' care choices. All women should receive information regarding the risks, limitations, and advantages of their care locations, care providers, and their maternity care. Very recently, I had a patient who requested a cesarean on demand, and I appreciated her point of view, and I told her that I, as a practitioner, do not perform. Came to surface, I would certainly consider the fact that that was her request. As it turned out, it did not happen, and she of this. We have patients that want what they want, for whatever reason that may be, and we have to make sure they understand the risks. Talk a little bit about the providers, sorry for that. Just so that we're all understanding, because I think not everyone truly understands the different So licensed midwives or direct entry midwives do not require prior training in nursing. And I think this is the most important thing to appreciate. In Arizona currently, you need to be 18 years of age, be of good moral character, have a high school diploma or GED. You have to be certified in basic CPR and NRP. The draft proposals that we looked at last meeting were 21 years of age, certified by North American Registry of Midwives. Of note, they have to have minimum 25 births as primary. So they have to have witnessed births, but 25 births as primary. Degree in nursing, followed by postgraduate work that leads to a master's degree level. And there are those that go on to get a doctorate level degree. And then obstetricians have an undergraduate degree, medical diploma, 4 years training in obstetrics and gynecology. And these are absolute minimum numbers. So this is the 10th percentile of national delivery numbers for obstetricians. 200 being spontaneous vaginal delivery, 145 cesareans, and 15 being operative delivery. Understand that most programs don't tolerate the minimum numbers. So just currently, as it stands right now, I was looking at some numbers from our residency program, and at the point of an additional year and a half to go, most of our residents have already achieved these numbers. Not most, all of them. Integrated systems. ACOG supports the collaborative practice model, the maternity care team, the integrated systems of care with established criteria and provisions for emergency intrapartum transport. Childbirth has become safer for mothers and babies because of improvement in medical technology and access to trained providers and emergency obstetrical care and neonatal care. At any time during pregnancy and the birth process, women may encounter complications requiring a change to facilitate timely communication and transfer of collaborative management of care. An integrated system depends on appropriately trained and certified practitioners at all levels, open guidelines, and patient education. Should women choose home birth, it should be attended by appropriately trained healthcare providers in a transparent continuum of care for the best possible outcome for mothers and neonates. The home birth attendant must have a system in place where consultants, where consultation with hospital-based and privileged, and looked at the draft for scope of practice. I wasn't reassured that this was part of the language. Can occur expeditiously in the prenatal safe and expeditious transfer of care and transport to a hospital for optimum continued between 37 and 42 completed weeks of pregnancy. It's a ballot presentation. Previously uncomplicated pregnancy. Who are considered high risk? In my field, that would be a vaginal birth after cesarean section, or I should say a prior cesarean section, multiple gestation, birth under 37 weeks or after 42 weeks, placental abnormality, non-cephalic presentation, preeclampsia, eclampsia, gestational diabetes, previous major surgeries of the pulmonary, cardiac, GU or GI system, or pre-existing medical conditions to include diabetes, hypertension, cardiac disease, and renal disease. Situations that may be catastrophic. Selecting candidates for home birth on the basis of low-risk status will not protect patients from unpredictable and potentially catastrophic emergencies. Such emergencies are best managed by the personnel and resources from home to such facilities may not provide timely and effective interventions to avoid serious or fatal outcomes. Situations that could be and may be catastrophic are shoulder dystocia that occurs when the head delivers but the shoulders get stuck. Prolapsed cord, baby's cord comes out before the baby's head and this can obstruct baby's blood supply. Placental abruption, placenta separates before birth and this leads to bleeding from the mother and decreased oxygen to the baby, or postpartum hemorrhage, acute severe bleeding after birth. Risk of birth may be reduced as long as there are enforced criteria to determine who is low-risk candidate for home birth and who needs consultation or transfer prior to birth or during birthing process. And I think this is important if we establish these criteria. Necessary to achieve safety.
We do ask if there are limitations, complications, consults, or transfers that occur during the birth. Out of the 3,100, there were 2,255 that had no limitations, complications, or consults. They proceeded to a home delivery without any of those. 759 had some type of limitation, complication, consult occur, or were transferred for care. And we were missing about 104 fields for that. When we look at, now this isn't the complete list, when we look at midwifery care that needs to be terminated before the delivery. There were about 211 termination of services. The most common being for a prolonged first stage, a prolonged rupture of membrane, failure to progress, preterm labor, elevated blood pressures, that they weren't presenting head down, that there was a prolonged second stage, there were 3 fetal demises that needed to be transferred, and then 3 needed to be transferred from retained placenta. Again, these can show up at any point during delivery, just like Dr. Manriquez said. Either during the initial workup as they were being given their prenatal screen, during the antepartum period, 67 had fetal conditions or complications. There were 266 in the intrapartum phase, 83 after the baby was delivered, and then 22 to mom postpartum. Just to give you an idea, and again, we can get further into this if anybody's interested. Out of the 67 that had complications with the fetus, 15 were for low heart tones, 2 were for elevated. There were 9 with irregular fetal heart tones. There were 2 cord prolapses, and then 11 indicated meconium staining. For the complications that occurred intrapartum for 266, again, this is just going to be your most common. A lot of them just had a N of 1, but not being vertex, prolonged rupture of membranes. There was 3 shoulder dystocias, 25 third stage hemorrhages, 12 retained placentas, and then 2 shocks. For the infants, again, this was the infant outcome. 462 had a completely normal outcome. 6 were abnormal, and we had 14 that expired. Again, we're missing the data. It may just be that the patients got transferred. Their care was terminated. Again, these are just blank responses. We were specifically asked about size of the baby. 46 of them were small for gestational age, 2,400 of them were appropriate for gestational age, and 260 were large for gestational age. And then again, we were just missing some fields. When we asked about transport, again, this is a very bulky reporting form. A lot of it is just free text where they write in what happened. We were asked about the number of preterm deliveries. We could find in the free text that 7 required transport for preterm delivery, but again, we can go through that text if anybody's interested in more of the outcomes. We were asked specifically about the APGAR scores. So 2,600 at 1 minute had above an APGAR score of 7 or above. 141 had 1 from 4 to 6. 30 had 0 to 3. We were missing some APGAR scores at 1 minute. And then 2,700 had an APGAR score of 7 and above. 15 had an APGAR score of 4 to 6 at 5 minutes. And 3 still had APGAR scores of 0 to 3. And again, we were missing some fields on that. Now, this is where I switch into that other data. But this is birth certificate data, so everybody who attends a birth has to fill out specific birth certificate data. So again, you can see the number of births are increasing. These are pulled from birth certificate data as anybody who had a midwife attending the delivery or was transferred. You can kind of see the counties with the majority occurring in Maricopa County, Pinal, and then Pima. Birth certificate data, we had 2 that indicated that there were midwives seeing multiple births. 21 with low birth weight. This is calculated by the birth certificate program. 24 were preterm births, so less than 37 weeks. There were 139 or 6% that were small for gestational age and 297 that were large for gestational age. On those birth certificates, it indicated that there was 1 maternal transfer and that we had 29 transfers for infant issues. These were just some of the complications or conditions that occurred that were noted on the birth certificate. And again, these could have occurred if somebody was transported to a hospital. They could have occurred at the hospital or at the home. That we don't have further follow-up information, but we probably will with the newest birth certificate data. Okay. There is a form that we gave the committee. That is, they took the quarterly reports, yes. And it's 2007 to 2010, so those are our overlapping years. And what they did was they matched the data. They matched the deliveries that were found in our birth certificate records to those presented in the quarterly reports. We were able to match about 60% of the births, and then you can see what was listed on the birth certificates.
Thanks, Kara. Is there any discussion on the data that Karen just presented. I mean, I have, not on the committee, but I just have a general comment, which is I mean, one of the things that I'd like for the committee to do is to come up with sort of some consensus at the end of this so that we've got a way to collect some data where we don't have so many empty fields at the end of this like we've got. I mean, one of the things you notice in that presentation is on so many of those reports, there's no data. Now, presumably, there's no data. It's probably more likely than not, it's a good outcome because it went, you know, as opposed to bad, but you don't, unless you have the data, you don't really know. So hopefully we can get to the point where, I mean, with the new rules, we've got a way of making sure that we capture better data.
I just have a quick comment about how you pulled the stats from the birth certificate and knew that it was from a midwife. How can you determine, on the old certificate form, birth certificate forms, how can you tell a midwife?
Yeah. Actually keeps dropping.
It was listed.
Sure.
Oh,
I mean, there's a field that says, was this baby born at home, but that doesn't necessarily mean the midwife was there.
Right, and so what they did, when they pulled it, this, and again, public health statistics is not my area of expertise, I had somebody else do this. But they looked at all of the home births, and then on that, apparently there is a field where it said whether it was attended by EMS, it was attended by a midwife, it was attended by a physician, it was attended by an uncle, that it was completely unattended. There apparently is a field that they can pull that out. So they pulled out all at-home births and all that had midwife as an attendant. Now, if that part wasn't filled out, we wouldn't catch that on there. So again, I think the new birth certificates will provide us with a lot better data.
Well, that box actually says other, right? Because we checked the other box.
Right.
So you went through, and from that, it's input licensed midwife.
They went through, and it can, they showed me all the fields, so it can verify between a licensed midwife and a nurse midwife. Apparently somebody's uncle delivered somebody at some time, so, yeah.
I just have a comment on the birth certificates. I think it's beyond the scope of the time that we have today, but I definitely have some comments from Northern Arizona on the new birth certificates. You know, our physicians and midwives, delivering midwives, don't sign or even see the birth certificates, so it's done by clerical people. And I think that's important for you guys to know. That's a part of why there are empty fields, at least in Flagstaff.
And so as we, and what she's saying is that that's under the old birth certificate system, right?
It will be under the new as well.
Under the new as well, it'll be filled out that way, at least in your facility.
In our
So
facility.
that's something we can take back to our vital records folks to see. I want to make sure that we coordinate the rollout of that new vital record system with birth certificates, which has been delayed by a couple of weeks, by the way. And make sure that we capture what it is that we're looking for. Any other? Yeah, go ahead. And you can, yeah, use the mic.
I have one more comment. Something I meant to share in my presentation and forgot. There, as part of the Smooth Transitions paper, there is a printout of statistics of why people transport, and it's taken from a nationwide, actually a North American study, and so it's all of North America and why people transport to the hospital. And there's a top 5 that basically were in line with what we found here in Arizona. Failure to progress in first stage, failure to progress in second stage were the top 2. 34% of transfers are failure to progress in first stage. Failure to progress in second stage was 12%. Pain relief was 18%. Maternal exhaustion 17%. Malpresentation was 14%. Everything else was under 10% of the reasons why people transport. And all of those top 5 reasons are usually non-emergent. Just wanted to point that out.
Yeah, that would be really good data. If you could make sure you get that data. If you
It's in
haven't,
the smooth transition.
it's in the smooth train. Okay, I haven't seen that
And
yet.
that's interprogram, or is it transfer or?
Intrapartum.
It covers everything: intrapartum, postpartum, newborn, and maternal. And I read of all of that. I read the top 5 things we talked about.
Yeah,
I can pass this around the committee.
Yeah, I'd be really interested in taking a second look at that. I missed it the first time, but that's really important because when you see data like that, you look at transport, your mind can race into thinking that, oh my gosh, it's got to be something really bad. But it's really important to look at what are the reasons. This is Washington data, right?
This is actually North America. This is Canada, America, and Mexico, reasons why people transfer from home birth. And then, so it's a nationwide statistics program.
So Kira, that's the other thing to check on our program. I mean, how much data do we have that kind of data?
It's all text field. It's all text fields, so what you guys wrote in your notes. So it would take us a little bit to go through and analyze the text fields, but we could get something done.
I mean, I think it would be important data to look at. You don't have to go from 2007 to 2010,
Okay.
but take some subset that's doable, and I can get you some resources from another part of the agency to try to look inside that for what we have on the quarterly reports.
But even the preliminary stuff you showed today are in line with the statistics that we have.
That being said, let's not forget that 10%. So
Right.
we have to decide, is 10% too low, not low? I mean,
Yeah, no,
I'm
that's
gonna
what-
throw that out there
right.
as well.
I'm sorry, what are you referring to? The transfer?
Well, I don't wanna overly reassure ourselves that, oh, just 10% of the transfers are catastrophic. 10% is 10%.
No, I just wondered what you meant by 10%, yeah.
Well, we're not saying 10% is catastrophic.
Yeah, even the catastrophic is like 2%. Otherwise, I just did the top 5. There's a
Yeah.
lot on there.
So,
And my point is, these are important decisions that we're going to be making both as a committee and as an agency. I just want to make sure that we've got as much data as we can to make sure that what we're doing is responsible.
Well, and in that light, the data, I mean, we're missing a lot of fields. I'm not sure how reliable this data is, but there's not a lot of continuity for fetal and infant deaths. The data is kind of all over. So I think that's one of the things that maybe we got to clean up a little bit.
Yeah, we certainly can. That was one of the things we noticed.
Yeah, I mean, I think it makes sense to take, this is a 3-year period, and I don't want to put the agency in a position to do it 3 years, but take a subset of that in an area where we think we have the best data and drill down a little bit so that when you come back to the committee, you guys can have some more in-depth information about what we do have on those quarterly reports on the kid side, baby side.
So, that's a good question, and I'm glad we in 97, how often we would look at this information.
I don't know if anyone was here. I wasn't. Well, I was here, but I was doing risk assessments at Superfund sites.
Moving forward, we are planning on collecting data. Moving forward, we are planning on collecting data that will be utilized to kind of track outcomes.
Okay, so now we're going to get into the big part of the agenda where we have an hour-long part. So we'll have, we'll see how much progress we make. We'll try to leave plenty of time for call to the public. Instead of setting a time period right now, let's just dive in and start talk about the
I'm ready.
scope of practice part.
I'm ready to dive in.
What I thought I would do first before I turn it over to Tom, and we'll go into the point-by-point details. I want to sort of set the big picture stage, and then I'll paint a large picture sort of the different categories, and then I'll let Tom get into more of the details. So, first of all, and I explained this at all of our rulemakings. Right now, we're doing a big rulemaking for our licensed facilities, inpatient, outpatient, behavioral health, etc. And we're using the same approach with this rulemaking as we use for all of our other rulemakings, including medical marijuana and everything else. It's what we do is come up with what I have been calling a straw man set of language so that we can get discussion going with our advisory committees or our more ad hoc working groups like we're using on the behavioral health side. So the approach that we took with the scope of practice is to sketch out some ideas around so that we could capture a starting point so that we could start looking at some of the scope of practice things, some of the collaboration things that we had been talking about at the previous couple of meetings, looking at it in terms of some of the more practical things around transfer, and that's where the ideas around the emergency action plan and so forth came out. So I sat down with my team in December, right before the holidays, and they worked through that holiday week to come up with what this is sort of a straw man set of language for us to for the committee to react to. I can't stress enough that this is not the final language, and every time we do a rulemaking, without exception just about, when people see the first set of language, they say, oh, well, that's what they're doing. And so they think it's final language, and that's not what this is. It's a starting point so that we can get a discussion going. And as we go through various iterations, the next stage will be to get closer to what would actually qualify as a draft set of regulations. So we'll put that draft language out for formal public comment. We'll get public comment on that set of draft language, and then we'll come out with notice of proposed rulemaking, and that'll be probably in late spring, early summer. And since this is an exempt rulemaking, at that point we're able to file that directly with the Secretary of State. So we have 6 months, which is enough time if we stay on task to come up with what I hope will be a consensus set of regulations that the committee can vote on. And if it's not consensus, hopefully we can get 4-3 vote or something a lot better than that. My goal is consensus, or at least grudging consensus, where everybody can live with what the final set of regulations are at the end. But I want to stress that we're open. What we want is to get a dialogue going so that we can get closer to the center, where we can get some consensus from the committee so that we can move forward. Because I really want to move forward with a set of regulations this summer where I can point to the committee and say, the committee's work made this possible. We've got some consensus on the committee. Maybe not everybody agrees with everything, but that we've got to a point where everybody can live with it. And it's supported by the data. And that's why the research that we commissioned with the U of A College of Public Health will come in. The data we have in Vital Records should help. We're looking at other states. So with that, let me start rolling through some of the slides before we get into the real detail. So you guys have, okay. So one of the first things I asked our team to do was to look at other states and see what other states do and allow. And so what you're looking at here is sort of on a continuum of what states do. And you'll see Arizona currently is that arrow that shows, and the way to read this chart would be to say that under certain circumstances, the current scope of practice includes breach. I know it's not an expert on what exactly you have to do to attend a breach as a midwife, but there's some ability to do that. If you look at Colorado, Idaho, Montana, New Hampshire, Wyoming, they allow VBACs, but not multiples or breach. See that? So that's what they do as a state. You could look and see Texas does VBACs and twins, Utah and Vermont VBACs and breach, but not twins, right? South Carolina, twins and breach, but not VBACs. So there's a combination of all the different states. And then you can see for VBAC multiples and breach, you can see the list of states that have that in the scope of practice for professional midwives delivering at home. So that's one of the things I wanted to do is sort of set the stage, and so our team did some research, and there may be some states that we missed. Tom, do you have anything to add on how your team did that kind of research? Just go by state, statute by statute. Kara did that? Statute by statute and looked at the scope. And there may be some that we missed. Do you have any discussion?
Well,
you're right.
okay, so there's 21 states up there. What are the other 29?
So they either didn't have any type of licensure for midwives or didn't refer to them. So these are the ones that actually license and regulate them.
So the other 29 would be under Maine and Missouri, unregulated then?
They have a license in Maine and Missouri. They have a license in Maine and Missouri from what we can tell from their statutes, but they don't have limitations to what they can do.
Okay, thank you.
We were trying to go back and forth between language. Yes.
And then this chart's up on our website, but it's also possible that we missed some states, and there's some states that we didn't capture, you know, because we're not perfect and we don't have infinite time, but this is from what we could find. Yeah.
So 2 points. First, I think it's important to identify what you mean by breach currently. And so that's important because it's not a knowing breach. It's if you are in the event of a breach delivery, then of course you can attend that delivery. The second is if we start going down the route of a numbers game, likewise with other countries, we have to respect that there are different settings. So for instance, in Washington, licensed midwives have insurance and they can get they have reimbursement from the state plans. They can get insurance, different than our state. So all of these states have different parameters that they work in, and I think it's important not to just throw out a numbers game, so to speak.
Right. And I agree. There's probably each one of these have a different statute, different set of regulations, regulated in different entities. You know, they're probably very different. But I just wanted to get. That's one of the first questions I asked my team is, you know, where are we on the continuum of interstates? What, you know, so this just, while it's not perfect, gives us a sort of a picture. So
we actually link the other states' statutes and rules on our website, so you can kind of go more in depth if you haven't already.
Did you use these states as a basis of writing what you wrote? Like, did you look at their rules and regs and?
Partially, yes.
okay, so let's press ahead.
Question on that, did you review like any of the evidence or articles when drafting this?
When drafting, we took into consideration some of the articles. I have not personally read it all. I'm not sure if my staff has. I can speak for them or Kara.
I'm specifically referring to the reports that were submitted by the midwives.
Reports, yes.
And the.
Yes. Those have been read.
Okay, so let's go to the next slide. I don't want to spend too much time on this. This is just this statutory language. This is just the rules. Okay, so this slide really talks about the broad sketch of the it says proposed, but I wouldn't have used that word. The straw man set of language that we're looking at today. So one of the things that I thought was important to include for discussion purposes is the merit of having a required emergency action plan and the regulations, so that if we were going to expand the scope of practice, that there would be some planning that would be required up front to ensure that the midwife that's attending the home birth, let's say it was twins, would have, and like you said, you probably, many, if not most of them already do it, but to have an organized way so that there'd be something in the file to identify that they'd reached out and figured out, you know, where they would most likely be going if there needed to be an emergency transport, the name of the entity that they'd be calling for 911 service. If it's all different, you know, we have a CON system in the state, and it sometimes can be confusing about who's going to actually pick you up when you call 911 and where you might end up going, because like hospitals, because of the flu right now, a lot of them are on divert for different reasons. Some are at different capacities, and the EMS may bypass hospitals. So we thought, well, let's bring up for discussion purposes some language around an emergency action plan that would be filed and kept on the file, so to ensure that there'd been some upfront planning in the event that there would be an emergency. The next piece was around informed consent. And I know we talked about informed consent at the last meeting, and I wasn't at the first meeting, but that's always been an important topic, and it was in your report as well, right in the first couple pages about informed consent being an important part of this. So I thought, let's put some language together for discussion purposes to really talk about what that could potentially look like. And so this represents, in your language here, one idea for how we might approach that. And we'll go into the details a little bit, and we're not wedded to it, doesn't have to be this way, but my thought was that we would have the consumer meet with an OBGYN once. They didn't have to go over and over again, but to get the perspective of the OBGYN about the idea around having, let's say it's twins again, to having a home birth in that situation, so that the mom would have an opportunity to just listen to the OBGYN, and then to be a documentation form that would show they had a conversation. And it's not a permission slip, and if you look at the form, and we'll go over the form in a little bit. If you look at the form, the idea isn't to have permission, but to just document that the conversation happened. And the way it was written in the rules, in this language, it could be in person, it could be telephonic. It doesn't have to even be in person. It could be on Skype even. It could be, any combination is the way that has been written.
Can I just say something about this document? Is it an appropriate time? There's, from my understanding and my work in the community, there's no obstetrician that is going to sign or meet with a woman and go over this. And when we pulled up statute, I'm not sure, the ARS 12-573, limited liability for treatment related to delivery of infants, exception and definition. Right now, if I transport to a facility and the on-call physician assumes care for this client, they're not held responsible because they never saw this client during prenatal care or intrapartum care. If an obstetrician sees a woman in pregnancy once, then he potentially could be liable.
Okay.
And that's something that I just wanted to make aware. And one other thing, in draft rule definition, you have the definition of a physician as a medical doctor, a doctor of osteopathic medicine, and a naturopathic physician that has an obstetrical practice. And I don't understand why a naturopath isn't included on this document. So that's just my concern I wanted to address up front, that no physician is going to sign this. And what I was looking at here on the physician's attestation, and that the client may decide to proceed with an at-home delivery regardless of my recommendation. What does that mean? If I gave this document to a client who wants to have a VBAC at home, and she went to every physician in the state, and no one would sign it, would I then just chart that no physician would sign it, no physician would see her? Am I still allowed to attend her? There's just so much here, and that almost every midwife I've talked to would like to completely strike this document.
What's the other perspective? Yeah.
I do have a perspective. So I somewhat, if not entirely, disagree with you, Mary. It doesn't make us liable.
Okay.
If we review this and we give our opinions and we communicate, document our opinions, patients do this all day and night. We give our advice. If they elect to not take our advice, they sign a document saying against medical advice. And that honestly is viable in this circumstance. But the patient should have an opportunity to hear a different perspective.
Absolutely, I agree with that, but would you sign this document? Because if you personally, as a physician, would sign this document or would see my clients, I want your number. Because if this moves forward...
It's 344-5444.
Great. And one other note on that, with this particular document, I lost my thought. Sorry.
You can have it back if you want. You're probably correct with physicians. They'll probably not sign that today, but what we're here about is change.
Right.
And if the physician community, there's value to midwives, there's no question. If the physician community is more comfortable with the way the midwifery practice is done in Arizona, you might find some willingness to work. It's not there today, and it's not there for a reason.
I remembered my thought. My thought was in addressing you and getting another perspective, because that's what I really got out of this document, is that they're saying here that you want to get informed consent, you want a different perspective, because maybe a midwife isn't capable, or maybe the client isn't able to research on her own. And if you want a medical potential, a physician's viewpoint on that, my suggestion to that would probably be a DVD or a video. But the only concern about that is they don't have the opportunity to ask questions face to face. So that's something that I think we can look at, is if they can get a perspective that the physician then isn't held accountable in any way, shape, or form. And they are reviewing the medical records. So that was a thought I had about meeting that requirement, some formal documentation that they viewed this video or they read this document, so they get another perspective. So that's respected.
Allison or Julie, do you have I don't know, get your perspective about the
I think what Mary's saying right there is that I guess what I hear from the consumers and for myself as a consumer is I don't really get why I have to go to a doctor who I know. I mean, if I found somebody who would say yes, go to your home birth with twins, VBACs, or just period, just go to your home birth, it would be amazing. I would be shocked if I find anybody who signed off. So what that's saying to me is that I need to go to hear something I already know. I have to go to these doctors who I know are going to be against what I want to do. And I guess I don't see the point. It seems like a lot of hoops to jump through to get a no. And we already know the answer is no. When I can find all of that information, I can go to ACOG's website and find all of that information on there. And I don't see how the stuff that's in the document that they have to sign, they won't find out anything new from that document. You know, I won't go to a doctor and they'll find out new information because they're just looking at the charts that I already have, that my midwives can detect.
With all due respect, I find this kind of insulting. What this says to me as a consumer is that you're going to second guess or that I need more information before I make a choice of providers. I don't see this same sort of bias being put when a woman walks into an OB's office and says, I want OB care. We don't send her to a midwife and say, well, are you really sure? We really need to make sure that you're making a good decision.
So what, from a consumer perspective, what would you like to see in the next iteration that you think would be a response? Just talk about what, I know it was in your report, but talk about a little more depth so that our staff can capture what, from the consumer perspective, might an appropriate informed consent look like.
Well, I think it's up on the website, right? Texas is
Yeah, Texas.
Their informed consent sheet, and go ahead and put all the risks out there. Anything that you would find in any journal article that would describe the risks of whatever, breech protocols, whatever, and let us look at it that way. I just feel like this is a big hoop to jump through where we can read, and so let us just read it and sign it and say, okay, this is something we really need to do. Or we read it and we talk to our midwife and decide, oh, wait, I don't want to do that. That's more risk than I thought. And I think it's really important for these informed consent sheets to have all of that data and to show what the risks are. And likewise, not just what the risks are of not having your baby in the hospital, but what would happen what are the chances of, if I'm a VBAC mom, of me going to the hospital, what are the chances that I would successfully deliver vaginally? Because we need to look at it both ways. Mm-hmm. This is informed consent. We need to look at all the relative risks. What are the risks of staying home, and what are the risks of going to the hospital? And that's why most consumers who want to have their VBACs at home would believe it is the safest place for them to have a vaginal birth. That's what we want, is to have a vaginal birth. And so we know that staying home might ensure that for us. And I just think it's insulting to feel like I have to go to a doctor to tell me stuff that I am more than capable of researching. And I don't think that we should make rules because sure, there might be some people out there who aren't going to do the research, but that's insane. That's on them.
Right, and I'm not arguing with that. I agree your perspective, but I was just, and I wasn't trying to insult anybody. I just was trying to set up something where there would be some checks and balances in the system to make sure that folks really were informed. And so
And I
maybe
think-
this doesn't capture it, and I don't know exactly what's in the Texas one. It's signed by the consumer, right? By the mom.
Do you have a formula?
I do, I have a copy of it.
Yeah, it just explains the risks.
So Allison, I just have a question. Are you a firm belief that every patient who decides to deliver at home is someone that is capable of doing everything you said you would? I mean, you have a master's degree. I have an attorney here. Is every home deliverer with the same capacity to extract the information and understand it to your extent? Because when I look at this data form that most people in the audience don't have, the highest rate of delivery midwifery or seeking midwifery services are self-pay, and I would just leap to the idea that perhaps this is because they are economically driven to choose. Maybe not you, maybe not somebody else. But I would like to point out that that's a factor. And so I think in doing this, the state was just putting something else out there that would guarantee, or at least try to guarantee, that the patient had a different perspective. Because maybe not all patients are the same ability to extract from the internet or wherever else. I deal with patients who have health literacy, and sometimes they just need someone who's had years of experience to explain.
Right? You explain to them.
Of
right?
course they do.
And just like, these women on our committee have years of experience as well, and they can also sit down and explain. We're not like, I don't think
There's nothing wrong with a second opinion.
No, there's nothing wrong with a second opinion, but it's the same idea, right? Like, so if something happens in your obstetrical practice with a client, you feel like you're qualified to discuss it with them. You're not going to send them to somebody else.
Oh, I always recommend my patients seek second opinion. I'm sorry, I'm
But
a
I'm
big
not-
believer of a patient being as educated as possible.
Right. I'm not explaining myself correctly. But we're two different philosophies, right? And so you believe in, or ACOG as a whole, right, supports birth in hospital, not at home. And there isn't anything that you can provide that your opinion, or anybody's opinion as a physician, that we couldn't find on our own. And yeah, there's people out there who can't find that information, but then their midwife can provide that to them. And they can reach out other ways. Just like if you're a patient, you would provide them information. That's what you would do. And we have to trust him. If the midwives here are governed by the board, then I don't understand either. You govern the midwives, and it seems like what you're asking is, physicians to.
So what? Here, let me try to see where we try to get a roadmap to the next iteration of this. So what if we came at this in two different ways? Number one is to have a form that's a lot more like Texas. I mean, this is a really small font and it's hard to read, and I'd like a little more than Texas, just because it's dense. This is a difficult thing, but the concept, I think, is something we can work with. What if we had sort of a two-pronged effort where there'd be a form to sign that gave it in words like this, but then the department, we made some videos that would be like 5 minutes long, where we could have the physician, we'll decide who later, but someone who would describe risk, and there would be different vignettes, like one would be twins. Okay, so there'd be a 5-minute video on twins, a 5-minute video on breech, a 5-minute video on the VBAC thing. And then the form would say, I attest that I watched it and I understood what I watched, initial. Then language like this, then that would be in the midwife's file. From a consumer perspective, I'm more interested. Your body language is
Yes.
good, but Julie's isn't.
It depends how it's done. I mean, I think that's almost insulting to the midwives. Now they're saying to them that you can't provide effective informed consent. I have two general comments about informed consent. I think with this population, I think it's less of a worry because the people you see seeking home births is not a slice of, the American population. You're typically seeing upper class, white, educated women who are seeking out these home births. So you're seeking a population that already has far more information than an average consumer. Secondly, I think a blanket informed consent, and I think almost any lawyer would tell you this, is a terrible, terrible idea. The idea of informed consent is that it's a dialogue. It's a continuing dialogue. It happens all throughout the labor. As different events occur, there needs to be different informed consent offered. So I think as a preliminary, the Texas form isn't bad, but I mean a video that presents a different perspective. I'm still not clear that's needed if we have midwives who are having this dialogue with their patients.
I'd like to just comment that sitting here, the dialogue seems a little bit dichotomous. On one hand, we're trying to encourage smooth transition and incorporate collaboration. On the other hand, we don't need the doctors. So this is one opportunity to engage the physician, because at the end of the day, when things don't go right, that's the person that is going to try to make right of what they can. Okay, so I appreciate your autonomy. By all means, I appreciate the autonomy of every person I take care of. At the same time, first and foremost, my obligation is to do no harm. And if a person decides and chooses, just like that patient I mentioned earlier, she wanted a cesarean. Well, she cannot force me to do a cesarean on her. Okay? Likewise, every patient that walks into a hospital has the right to refuse whatever procedure there is. So, quite honestly, I'm having a little bit of trouble with this dichotomous discussion.
Well, I guess what I'm not clear about is how the discussion happens between these women and the doctors over a video. I guess if that's the next proposal. I'm not sure that that's...
I think a discussion over video is not even a viable option.
But
I just threw it out there. You guys don't like it. I don't want to make my staff do something that's so good.
No, my comment more generally though is if your client really wanted that C-section, what she does have is choice of providers, and she could have sought a different choice of providers. My issue about this thing in general is that it's a non-consensual second opinion. This is an opinion that the woman doesn't necessarily want and doesn't feel that she needs, but she needs to sign off on it in order to have the kind of birth she wants.
I hear what you're saying, and I think at least the way I interpreted it was this was the health department's way of at least making sure that there was other perspectives provided to the patient. I mean, I reviewed some of the comments in your online survey, and we have to be aware of the fact that individuals are doing whatever they decide to do anyway. One person talked about underground, which implies that they're doing things that are not already legal by these guidelines. So I don't know that that's going to change, but I think it's wise on the Department of Health Services to implement and have things that are at least going to give some assurance that there will be a different perspective provided. The patient doesn't have to, patients just do what patients do.
Well, maybe the health department can provide physicians or have a contract, a 20-year contract with the physician's practice or a group or something. But the majority of physicians, I think, just because of what you clearly stated in your presentation, liability insurance. They are not going to meet with our clients. And what I'm sensing is with this particular document, we're falling into the realm of the Department of Health allowing licensed midwives to attend vaginal births after cesarean at home, but it's unobtainable. It's like New Jersey. Licensed midwives can attend a VBAC in the hospital, which is, it's unobtainable. So what this document has done is saying, yes, you can do it, but really we can't.
I can just tell you, that's not, whatever you think that I was trying to do, that's not what I was trying to do.
I understand that.
I'm trying to make it work. I'm not trying to do a shell game so that there's, so that I can say I expanded the scope of practice and didn't.
Right,
I'm just
I
telling you,
appreciate
I'm not
that. I
that kind of guy.
appreciate it. I appreciate it. And just know from our perspective, we're just seeing that is, it's just something that realistically isn't going to happen. And if we can come up with a compromise, a way to make it realistically happen, I'm all for that.
I think there needs to be, I mean, I think the Texas thing is a good starting point, but it's just so dense, and it's, I mean, it's just, it's like when you're shining an insurance policy or something, you know? Who really, I rented a car the other day, and I'm not going to read all that stuff, and you just end up signing it. I don't want it to be like that, where it's like, oh yeah, just sign here. I don't want that, because that's not informed consent. That's just CYA.
That's right.
You know, I want something, an idea that's implementable and doable and achievable, and that will actually happen in the field, that builds more relationship and makes sure that everyone really is informed about it. And so maybe it's not the video, maybe it's some other kind of thing. I don't know. I'm trying to get it in my head. I don't know what it is yet, but if you have an idea, the appropriate way to do it is to send your idea directly to Kara, but not, because if you do it to the whole committee, then we've created a meeting online, which we can't do. So send your ideas individually or onto the website for what it might look like, and if there's another state that has something that you think is there. But I don't want it to be fake. I want it to be, thought-provoking, because this is a really important decision, you know.
It is.
So it needs to be real. Somehow.
We support that.
Not what we just turned in, so don't worry about that.
Yeah, we totally support a woman being fully informed in making her decision.
Okay, so that was supposed to be a couple minutes. No, let's go back, because so the next thing is sending the prenatal records to the maternity ward of the hospital identified in the emergency action plan. The idea there is, I think we said it 32 weeks. I don't know if that's the right month, but so that there's a medical record. So if you could predict where you might end up in an emergency, that there's a medical, hopefully an EHR paper that would end up there. And then the idea is when labor, let's say it was a VBAC, when labor started, the midwife would call the hospital and say, okay, I'm doing a VBAC, I'm attending a VBAC in the community, and you have medical records there, and I think everything's going to be fine, but I'll let you know. And then at a minimum, call when labor's over so that they can stand down if they were ready, staffing-wise, to in the middle of the night or something like that. So that's what that bullet is. Do you want to do comments on that one before we move on? Yeah.
I wonder what the. Oh yeah, I was going to ask what you've got on that since I don't work in a hospital.
Yeah, okay, the problem I have with that is hospitals don't practice medicine. So sending something to a hospital notifying the maternity ward is nothing. You need to have a doctor to provide. That puts the hospital in a very bad position. I don't think the hospital's going to be very happy about that. I'm not saying I'm throwing the whole thing out. I'm just saying you've got to have a more specific notification to the person who may eventually end up having to care of the patient. I've been there, I've done that. I do that up until I retired. We did that in White River. They can't do C-sections in White River. So whenever they had a patient that they were worried about, they called ahead because it's a doc-to-doc, not a doc-to-maternity ward. That doesn't work. I can tell you from experience.
So from your perspective, if you were on, you were on duty, and you knew there was a VBAC happening in the community, what would you want, prep-wise, in the just in case kind of scenario?
One thing, and especially in a hospital like ours, where we only have 2 ORs, I want an OR built. You know, that would be something that would be specific to our particular rural hospital. But a nurse can't do that. A physician has to be in charge of that. You have to set up for the what-ifs case. And we do that all the time. We have a lot of experience with that in a rural setting where we have limited resources, limited staff. We may have to, you know, we have 4 people in labor, and I got a phone call that somebody's doing a home delivery on a evac. I'm going to bring more staff in. I'm going to have more staff that I can call in quickly. Because remember, I mean, my wife's an RN. She drives an hour one way to work. There's big distances out there. And, you know, when they call and say, I'm sending in a VBAC that's bleeding from a home delivery, that's not the time for me as a provider to start, you know, bringing my troops together.
So there's value in knowing that it's happening, but not that much value in the medical record, right?
I'm not sure I follow you.
So, well, I think something that's important, and since Mary requested to have some presentation time, I would like to request that Dr. Northup have some presentation time specifically talking about our transport system in this state. We already have a quite elaborate transport system. Wouldn't it be nice if the the licensed midwife could communicate with that system and they be on alert to know exactly where, who, how, when? Indeed, it's true that if you call, let's say Mary called me at work and said, hey, this is happening. Well, there's some issues and some unfunded mandates, for lack of a better word. I have an insurance carrier. I have a hospital that may not be happy with this, a risk department that may not be happy, but we do have an elaborate transport system and an Arizona Perinatal Trust that it has, you know, vested interest in communication. So, and they too will be the first responders. So something to think about outside of let's just send our records to some hospital and hope that they're available and somebody can find them when that patient comes. Because when that patient comes, it isn't going to just be, albeit it's true that the majority of the transports, and hopefully the communication exists, that this patient has had a prolonged, protracted course of labor. And I'll go back to that story because I have an anecdote story on that. But there will be those crisis times, and that's not when you want to be fishing around for these documents. So understand the lack of communication between provider to provider is the issue and what we're dealing with right here and right now. And that too addresses the scope of practice. So until we clean our house, and I'm talking about the health department, we know outcomes and we're looking at what is going on and we know how the process is working right now, I think it's not yet time to increase the scope of practice in any way, shape, or form. And I'm adamant on that point. So I imagine the day will come when there's a vote for consensus. You're probably not going to get you're not going to get my vote. You won't, because we're not there yet. Could we get there? Possibly. But we're not there yet.
So go back just for a second on the transport. So for the next iteration of the rules, I need to have something that I can sink my teeth, our team can sink their teeth into about if we, I'm not saying we're going to definitely expand and stuff because it's a committee decision in the end or recommendation, but if you were going to have, what is the most important piece? Is it the communication with EMS?
I think, in my experience now, being at a stationary facility, and we transport primarily to one site, I have the attending's pager. So if I'm transporting in, I page the attending on-call physician. I give them the summary. I let them know. I then call the charge nurse, alert the charge nurse that we're coming. And I had a transport recently. I had heart rate decels during pushing. I activated. I called when we were getting in the ambulance. When I got into the ER, they had an OB team waiting. It was fantastic. It was so smooth and it was wonderful. The outcome was great. She had her vaginal delivery and everything was fine. But I had it streamlined. And that's part of the reason why I requested to be on this committee. Because that's what I want to help with in this state.
So what could we put into a generally applicable rule that would work? I know that's working for you right now. Right. But what could we put in a generally applicable rule that would help improve that outcome? Just think about that.
Well, if you'll give me 10 minutes and a future meeting. I'll address this from the perinatal regional system point of view. One of the things that I'm going to concur completely with Maria, and you also, we don't have a system right now where there's collaboration between the midwifery group in the state and the physician group in the state. It's been done elsewhere. We can do it. But you can't take the giant step first. You have to take baby steps. And there are some baby steps that will get us there. Maybe not tomorrow, but by July. But they can get us there appropriately and safely, as maybe have been done in other states. But I think we have to do our best practices. I don't think you can take Arizona and compare it to very many other states. We are unique because of our geography, because of our distribution of Indian health service and everything else, and our transport system. I will give you some very interesting stuff when you and Kara give me 5 or 10 minutes, and then we can use that as a springboard. But I think when you see what's happened in Arizona in the past and what can happen, you see, I think you'll start to see how you're going to structure your scope of practice.
Okay, Mary Ellen, are you still here?
I am.
Okay, are you taking notes? Okay. Yeah.
Oh, I would concur with all three of you as well. I don't think that we're in a position right now to, I think that we have to look at the structure in Arizona and fix that first. I agree with that. I think that's wise. And if we take on expanding things before we're ready and before we have a collaborative system where there's fluid access to every level of care, we're putting everybody at risk.
Yeah, just by the way, there's creative ways to craft this rulemaking so that it can be rolled out stepwise. In other words, there could be dates that get put into the regulations that say, by this date, this needs to happen. By this date, this needs to happen, and then on this date, the scope of practice changes. In other words, the rulemaking is filed on July 1st of 2013. That doesn't mean the scope of practice has to change that day. We can write the rules prospectively so that there's a planning process. At some future date, that scope changes. And in the meantime, we put some onus on the department, our job, to do certain things before that time. I'm just saying that there's ways to do that. Did you have okay, so we'll make some revisions on the client records because that's probably doesn't sound like that's the most important part of this. And Mary Ellen she's with our maternal and child health group. We'll use some of our Title V dollars to try to work on that piece a little bit. The next one, which was in the rules, was about calling when labor began and afterwards. Because that's kind of what you were. We probably worded it wrong because we might not want to. You don't want to call the hospital. What's the
notification has to occur? It's just who and how, so that'll be crafted later. But yes, there has to be communication, but it's not real comfortable with the way it's stated
right
there.
So, okay, so we'll make some modifications so that it's more.
I guess I'm confused as to why that communication, like especially calling somebody or a hospital or whatever when the labor begins on a situation that is less than 1% chance of happening. There's so many other things that have more of a chance of happening. So are we supposed to call every single time a labor goes on? Because we're talking about something that has less than a 1% chance of happening. And we're going to notify every single time a VBAC goes into labor? Is this what I'm clarifying more than anything?
This was just for the expanded scope, not the normal things. And I'll be honest, what I was thinking, I thought I was driving on my way home, I thought of this one. And one of the things I thought was, wouldn't it be nice if the hospital knew what was happening, that there was a VBAC happening in the community, and they knew ahead of time, and they knew when it ended, so they knew it was successful. In other words, sometimes I think that what they see is the bad outcome, and they think that it's bad outcomes all the time, and they don't see the good ones because they're just happening in the community and no one knows. So with this approach, they'd be like, oh, what happened? And they stopped, and that must have been okay. So maybe that's not a useful thing, but that's what I was thinking when
it's quite useful. I mean, we have practitioners that are family medicine doctors that do that, and it's collaboration. So how we get there is the issue. How we get there from where we are. People and stakeholders that aren't at the table that possibly should have been at the table are, the hospital association and the underwriters for the insurance. There's some things that we're going to be limited by, and those are the reasons. But they're not here to hear the voice. We don't know. So it's a very good thing. And yeah, you make believers out of people that see success.
Well, I definitely think we have to also remember the northern other communities where they don't have hospitals as close and don't have support from any physicians. Another thought is, looking at those communities out there and addressing their needs specifically, but what about, I just keep coming back to these women who are birthing unassisted because they can't have a licensed midwife attend them because it's prohibited practice, and I really don't want to delay the expansion. I think about these mothers and their needs, and I definitely think it is safer for them to have a person who is licensed, and no one knows better when to transport a laboring woman than a licensed midwife, and that's because we're in the homes. We're not medical doctors. We don't have, we're not nurses. We are midwives, and we work in the home. So it's completely different. If you're a nurse, if you're a doctor, you're working in the hospital. You don't know what it's like. So these women out there alone, that are birthing alone, to me is, it's a public health issue. And that I don't think should be delayed on expansion. I definitely do believe that communication is important, but I also want to address, like in the communities where midwives can't openly communicate with physicians, the physician won't come in the room if the midwife is there. There are signs posted at hospitals in northern Arizona where midwives are not allowed on property. This is the kind of things that are happening in certain counties, not Maricopa, in Yavapai County. This is a serious issue. So, and the majority of mothers that spoke at the last meeting, which is, I think, very relevant, these women speaking, is very relevant, they're the ones that were having their babies unassisted.
Okay, we got to press ahead because we're falling behind a little bit, but so we captured those. Another bullet about coordinating with EMS, that was in those regulations. We skipped the physician consult for now because we're going to come up with something a little bit different next time. So this is probably more of a presentation. Let me just do the big picture, and if you have any questions, you can talk to Kara about these. I asked Kara and her medical group and her team to look into this. I said, if we're going to do expanded scope of practice for VBACs, let's make sure that we're looking at it with closely. So it's not just bullets, VBACs. To say, I think my question to you was, are all VBACs created equal, right? Are there some that are more risky than others? And so she looked into it, and that's why it says, for now, if the previous, you'd say the transverse and all that stuff.
Okay, so what we did was we looked at the scope of practice, both given by other states, things that were recommended by ACOG to be done in hospitals, recommended for a trial of labor after cesarean section, and kind of tried to write some of those guidelines and then would request feedback from the group on that. So if you look through the scope of practice, it does place restrictions on the number of previous C-sections, no greater than one at this point. The type of previous C-section, that it has to be a low transverse C-section, cannot be classical or vertical. The reason for a previous C-section, so these would be things that you wouldn't consider a trial labor of in, would be things like their C-section was for cephalopelvic disproportion or failure to progress, failure to dilate, things like that. The time elapsed since the previous C-section, we wrote in about 18 months. Or if there were previous complications, your C-section went okay, but you got a uterine infection afterwards, those types of things. But those are the types of things that we need the feedback on from the committee.
I had the issue with the failure to progress and failure to dilate, because I think, I don't know what the statistics are, but the majority of your VBAC moms are going to have that as their reason. And I don't know that there's any research that will say that that's a reason you can't be successful the next time.
There is
Lots of research done on just that.
Would you submit that?
Absolutely. So it's important that, as Kara alluded to, that these were recommendations for vaginal birth after cesarean, okay, in the first place, and originally in the hospital. So I think, again, extrapolating this to home setting, keep in mind that strip that I showed you. That's often all we have. We often don't have blood from the vagina. We often don't have a loss of station. We often don't have pain. So all we have is a strip to go by. And you're right, I don't deliver at home. So I don't know if you use continuous monitoring at all, or if you're just using auscultation. So again, this criteria was developed for when to do a VBAC, and we nationally, ACOG is a proponent of VBAC. Our hospital, the hospital I practice in at Maricopa, has a very high success rate. We try to VBAC as many patients as we possibly can. I think it's important to not, again, extrapolate this information to the home setting.
Another issue with, just students' blanket failure to progress or failure to dilate is how many, what about a mom who wasn't progressing because her labor was augmented? It was, failed induction. And that's why she wasn't progressing, because she wasn't ready. I think there are just too many, I don't think there are very many consumers who would be comfortable with this.
So we're going to do more research on it to make sure that in the final analysis that this is right. But am I reading this right, Tom, that the regulations that we would put forward would be regulations for the midwife to follow, right? And if she believed that it wasn't, that the chart indicated a different reason from what the restriction was, that they could, what I'm saying is there's judgments that still can be made in the field regarding whether they're in compliance with the regulations or not.
And there's another set of criteria which leads to higher success. We use a calculated model for our VBACs, you guys. Just a calculation of risks and benefits. So if a woman has successfully had a vaginal birth after a cesarean section, then she's at lower risk for having complications with another one. So my point is that there's positives that you can put in here as well.
Right, and on page 10, we were looking in the rules on page 10, some of the things will see question marks, and that's where we need more details about that. And for example, that's why one of the things is if you've already, let's say you had a cesarean and then you had a successful vaginal birth after that, then you could just have another, you could just do it. You know what I'm saying? I'm not saying that, but that would be in the scope of practice.
If you expand it, but not as it stands now.
Right. No, under what we had written here.
Yeah.
Yeah. So we're looking for, if you look at page 10, the question marks are triggers for the committee or anyone from the public to give us more information about those things. So that's area. And the other things that you'll see is Kara, right? We limited it to twins, not triplets or more, right? And then there's also a thing about you were telling me about 1% or something for twins.
I would like to recommend that we take each of these parameters or each of these different entities in the scope of practice, and we're not going to accomplish this tonight. We're not going to get where we want to be in any way, shape, or form. So we should probably take each one separately, because there's a lot of research on each one individually. So,
okay, so
I realize we're shortchanging our public here. So
Yeah, no, and the idea for today was to go over the general sketch and not get into the details, but we'll have time to get into those. I just wanted to present that. And with that, I think that's pretty much our last slide. There's some elements that we'll go over later on the restrictions on the number of fetuses and slides on that. Okay, so with that, let's go ahead and press ahead to the call of the public. We have 15 minutes on the agenda for that, and then if the committee will stay right after that, we'll set the time for the next meeting. And with that, I'm going to hand it to Tom Salo. I'm going to take a quick break.
All right, we have a speaker request forms filled out. I'm just going to read off the names. We'll probably give you probably just a minute. Max, maybe 30 seconds now. I'm going to start off with some people in the other room. 10 seconds. All right, first off, Paula Matthews. Are you here?
Yes. Can I just speak from here?
Here's come with a microphone for you.
I just want to express my concern about the proposed requirement to have a written agreement with backup doctor and also written letters of recommendation for any student who wants to apply for a midwifery licensure. First of all, I want to say that we tried this in the 90s. It had to be dropped because the doctors were not willing to sign. I believe that there's a certain lack of understanding about how home birthers and midwives work. Students are not going to have enough exposure to MDs for an MD to sign off on their ability or write a letter of recommendation. And I feel that if this goes through, you're just going to have a lot of midwives that will be out of business. I also want to comment on the question of the VBACs. I live in an area that where women's choices are limited. You're not going to go into a hospital and get a VBAC. Your choices are, number one, have a C-section. Number two, travel 100 miles to a hospital while you're in labor to have your VBAC, or to have an unassisted home birth. Unassisted home births are alive and very well in the area because women do not have access to home birth midwives who can assist them with their VBACs.
Thank you. I'm going to limit to about 45 seconds, though, so sorry if I cut you off. Etha Fink.
So, hi, I'm Etha Fink. I'm a resident at Maricopa and St. Joe's. At both of these hospitals, I've worked closely with nurse midwives, and I fully believe in their capacity to successfully deliver a vaginal delivery. However, when we talk about trial of labor after C-section, as a resident, I consent these patients for the trial of labor, and I go through all the risks and benefits, and we talk about, we go through the informed consent process, and a big part of that consent is me telling them, you have a 1% chance of rupture, but I still recommend that you try for vaginal delivery because you're here in the hospital. If anything goes wrong, we can take care of it. And I've seen my fair share of uterine ruptures, and we rush these women back, and we do a good job, but it's still stressful and scary. And I can't imagine that 1% making it to the hospital and still having a live baby. And I think that is scary.
Thank you. Patricia Graham.
So I'm Dr. Graham. I'm an OBGYN also at Maricopa, and there were a couple things that I did want to address. First of all, I applaud the information on the website that says you're going to use evidence-based practice to make your decision. Although listening to this committee tonight, I'm concerned that what I hear, the statute said you were going to consider expanding scope of practice, and what I hear is developing for expanding the scope of practice. And there's been no discussion on whether expanding the scope of practice for the deliveries that are very complicated are actually safe to be done at home, and whether our licensed midwives actually have the experience and skill to handle the situations that arrive with this. I'd like to address specifically breach. Within the last few years, was the unfortunate, I have to tell you this though, because a licensed midwife labored a breach at home, knowing it was breach, I got called to the emergency room, the baby was half out, the head got trapped, and we had a horrible outcome, and that was knowingly done.
Thank you. Joanna Wilder?
I think that this is such a valuable discussion on establishing safe and collaborative practices, and recently had the opportunity to have a beautiful transfer experience at a hospital that was received by other professionals directly, and the hospital was very cooperative. As a nurse working in out-of-hospital settings with CNMs and OBs, I really respect the perspective that hospitals and other professionals don't want to receive transfers that are what they call train wrecks, which is kind of a derogatory term. But I think that if we're able to put a wise and well thought through system in place, it's going to serve our community to provide ways for our midwives to practice in safer manners and the consumers to be able to have more choices in making wise decisions for their care.
Thank you. Lucy?
Thank you. I'm Lucy Hosmer. I'm a practicing certified nurse midwife, also over at Maricopa Medical Center. And I'm interested in the idea of evidence-based practice, because when we talk about expanding the scope to include breech, twins, and VBACs, and I look at the table that you constructed on the different states that you say allow that, when I went through the document, I went on the website and tried to read as many of these documents as I can, it's not clear to me that those practices were actually being done, and there's nothing in the literature that supports safety of those particular kinds of candidates at home. And believe me, I have done a literature search to see what the evidence says. So if we're going to use evidence-based practice, we need to practice according to what the evidence is telling us.
Thank you. Ann Halser?
I'm also as a naturopathic physician, and I would like to ask the committee for 5 minutes of time at the next meeting to officially address the VBAC issue.
We'll take your,
I changed my, I know I wasn't going to say what I had to say in less than 45 seconds.
Can you provide me with your name and contact information here? Thank you. Janice Obey?
Thank you, Kara. Janice Bove, certified nurse midwife, Mercy Gilbert Hospital affiliated. We represent the American College of Nurse Midwives locally in the state of Arizona, and we asked for time to speak today, but we had some great discussions today. So we'd like to be on the agenda in the future, 20 minutes for the American College of Nurse Midwives in the state of Arizona.
Thank you. We have your contact information.
Yes, sir.
Deegan?
Apparently I'm a qualified physician because you can't read my handwriting. My name is Dean Coonrod. I'm the chair of the OB/GYN department at Maricopa Medical Center. Been practicing here in Arizona for about 20 years. Been active with the Arizona Perinatal Trust. I would ask that you look carefully at the 14 fetal deaths that were in your birth records. I'm quite disturbed with those numbers, and would like to know more of the circumstances behind those. I think, I realize we talk about train wrecks. I'm a little bit disappointed to hear any time a patient is transferred to the hospital, it's a tragedy. I would sort of put out there that any time a patient is transferred to a hospital and we have an adverse event to mom or baby, that's a real tragedy. And I think there is the potential, and evidence would show this, that perhaps expanding the scope of practice could increase those tragedies.
Thank you. Julia Olson?
Hi, I am a labor nurse. I am not a midwife. I'm a consumer, and I'm an advocate for safe healthcare practice. I want to urge the committee to remove item B, numbers 1, 2, and 3, vaginal delivery, VBAC, multiples, breech deliveries, in the interest of the obligation of the Department of Health to protect the safety of the general public. One death is too many.
Thank you. Dr. John Gallagher.
Thank you. I noticed up there that there was an item that said coordination with EMS. I'm the medical director for the Phoenix Fire Department EMS division. This topic, obviously, there's a lot of different opinions about where the state should go with this. And I personally think that changing the scope of practice for midwives and increasing the types of women in labor to VBACs, multiple births including twins, and breech will increase the chance of a catastrophic outcome. And I really don't think that that's something that is good for this state, for the women who are pregnant in the state. Thank you.
Thank you. Dr. Eric Royce.
Hi, my name is Eric Royce. I'm an OBGYN. I'm in chair of the department at Scottsdale Hospital. My name is Eric Royce, and I'm an OBGYN and chairman of the obstetrics department at Scottsdale Health Hospital. Excellent. The department had kind of spoken about this because we knew that this was going on, and we all unanimously, all about 20 of us, came to the conclusion that this is probably a very poor decision to go ahead with changing the scope of practice. There's a reason why the American College of Obstetrics and Gynecology limits and restricts and has very strong language in how obstetricians deal with breech, multiples, VBACs. All these things, birth has risks, and when you have a high-risk situation, it's not a matter of if, it's a matter of when you're going to have a complication. And if you have a complication, if the uterus ruptures, you're not in the hospital, it's game over for the baby and maybe for the mother. And until somebody has seen a ruptured uterus with the baby in the abdomen, it takes a whole different look. So I think it's also important to look at autonomy for the patient, but also of the newborn, because a lot of this stuff is basically impacting the newborn and not just the mother.
Peter Stevenson.
Hi, my name is Pete Stevenson. I'm the director of the neonatologist group, Phoenix Perinatal Associates. Is this coming through right? Yeah. Sounds good. I'll read very quickly to get done in my 1 minute, but all of our primary goals should be the safety of the infant and the mother. I don't debate the autonomy with respect to mothers. What my concern is the rights and my obligation to protect the safety of the baby. As a neonatologist that receives and cares for these infants, the risk to the baby is profound and potentially devastating. I also recognize from the data that was presented earlier that the data is extremely limited. This in itself is a major concern. 14 of the 482 reported outcomes were death. Even if it was the 3,000, 14 out of 3,000 for low-risk deliveries is remarkably high. I know my time is up, but anyway.
Thank you. If you guys don't have time to speak, also you might even submit comments online, and we do read them, we do post them also, you guys can view as well. Dr. Andrew Carter.
Andrew Carter, I'm a private practice OB in Scottsdale. I'm the former chair at Scottsdale Shea. And I'm enjoying hearing a really great debate. And I come from a training program that worked closely with CNMs in New Hampshire, was part of the New Hampshire-Vermont feedback project. My focal concern is the lack of information for the lay public to accurately assess the risk they might be undertaking with more complicated home birth in general, but also specifically with VBAC, twins, breech presentations. I think the data isn't there for them to access because so far it hasn't been accurately reported. So how can they make an informed decision? You can look at my Arizona perinatal trust records, and I can show you my VBAC rate and my section rate and happily share that with people. Pretty proud of them actually. But I'm concerned that the public doesn't have a way of making a good informed decision about the safety that she might be facing.
Thank you. Hugh Miller?
I'm a maternal fetal medicine specialist, which means that I'm a high-risk obstetrician and I actually live to take care of high-risk moms. I guess I would just echo many of the things that have already been said. I think not only do we want to appeal to the best evidence, but we also want to appeal to the highest safety standards. And as I said at the last meeting, I think what we should be looking at is expanding the scope of practice in the safest environments we can. When you, just as a brief comment, when we talk about the statistics that we have, as limited as they are in the state, they're on the basis, they reflect low-risk mothers. They don't reflect the population that we're about to usher in. So while at our institution, we're advocates of all of the things that are being sought here, we're advocates of midwives being involved in them, but we're advocates of doing them in a safe place.
Thank you. And the last one in this room is Pamela Qualls, with a few more from across the street in this week afterwards.
Thank you. Hi, my name is Pamela Qualls. I'm a licensed midwife, and I was going to talk on informed consent, and I just have to tell you, for all of the midwives here, it is very important. We spend a great deal of time on informed consent. All the scary stuff, all the not so scary stuff. I personally spend about an hour sometimes on informed consent and give my moms places to go look for research, doctors that they can talk to. This is important for us. We are not out there to pull the wool over the public's eye. I get that feeling that that's what some of you feel. That is not what this is about. With regard to the 14 deaths, I've had 3 of them. One was for a trisomy baby that didn't make it. One was to a stillbirth that was born to a mom with diagnosed lupus. 5 years later, she had seen a perinatologist who kind of said, nah, don't worry about it, no big deal. Everything looks fine. The last one was to a shoulder dystocia. I was met at the hospital after that shoulder dystocia by an OB/GYN friend of mine who had also seen this patient, said it was either you at the hospital, or you at home, or me at the hospital. The outcome would have been the same.
Thank you.
Stevie, go ahead with the first questions.
My name is Michael Richardson. I'm a single man. I have 2 children at home. When my wife was pregnant with the first one, we went through heavy reaches. The preference of hospitals to home birth. And what I have to say about what I've heard here today, a lot of emotional emphasis on death without proper statistics backing both sides of it. I'm really disappointed about that. The comments about economics and intelligence is just insulting. I have a college degree and I'm spending money on that. Don't bearing on my choice, but it does point out the financial conflict of interest here when spoken up. And in the big picture, maybe we should look at natural births as a way to save money and to get mothers in the hospitals that need to be there.
Thank you.
Steve, do you have our next comment?
Hello, my name is Kate Paxton. I'm a nurse midwife with Bethany Women's Healthcare. I practice at Phoenix Baptist Hospital. I just wanted to speak again on the issue of informed consent, on how much time we go over with mothers on informed consent, and I realize that I believe my home birth colleagues also do the same thing. I just really have issue with an idea that everyone, that the home birth clientele is of a different population. I think that we should be planning for a day when the home birth clientele crosses all types of spectrums, from low income to high income, from less educated to more educated. I really hope that we can reach out someday, and so I don't want to make our informed consent just be for people who are highly educated. Thank you.
Thank you.
Okay, Steve.
Hi, my name is Laura. I'm a consumer of home birth, a biologist, and a mother. I often look to the primary literature when making healthcare decisions for my family. I wanted to mention some examples and tell you a little bit about myself to illustrate one type of woman that chooses to birth her babies at home. I am putting the welfare of my child first. It is just an amazingly lucky coincidence that what is best for my baby also yields a beautifully empowering experience for myself. When I found out halfway through my pregnancy that I was carrying twins, I had a lot to research and process. My biggest priority to help ensure a healthy outcome for my babies was that I wanted to carry them to term and wanted them to come when they were ready. Also, I wanted to set things up so that we could have the best start to a successful breastfeeding relationship, which, as you may or may not know, has far-reaching health effects that can last even into adulthood. That setup is a vaginal, unmedicated birth. I also wanted them to come into this world in a peaceful way. A pregnant woman expecting twins and planning to birth in a hospital is extremely limited in her choices. Most doctors will induce prior to 38 weeks, many in the range of 36 to 37 weeks, and they will require you birth in an operating room with an epidural in place. Those conditions immediately eliminated all the priorities I wanted for the birth. Many of this trained or are unwilling to deliver breech babies. So cesarean birth is not an occurrence for a twin mom, it's standard. Every twin mom that has birthed in a hospital has had a cesarean. Consequently, I stood by my decision to have my babies at home. I had a beautifully smooth birth. I had 2 perfectly healthy babies and 1 perfectly healthy mom.
Thank you. We have one more. Do we have time for one more?
Yes.
My name is Michelle, and what I wanted to say is that the proposed rules increase obstacles towards our community's access for skilled, experienced midwifery care. I believe that the state of Arizona should be engaging the least restrictive path towards informed consent, not the most restrictive.
Thank you.
Okay, let's talk a little bit about the future agenda items and the closing remarks. We took some notes today about future presentations, and our team will start putting that agenda together. But I want to get a sense from the committee what's the best. We got a lot of work to do. You know, we only have about 5 months left, which sounds like a lot, but it's really not. What's your feelings about daytime, nighttime, 2 hours, 3 hours? You know, you want a couple of weeks before we meet again? You think we need 3? Give me some thoughts.
I'm up for whatever we need. Every 2 weeks, day or night.
Coming from 200 miles away and I had a day job, I like the night.
Oh, you do like night?
I do, yeah.
You gonna stay overnight? You're not gonna try back to show
Yes, I
me.
am tonight, holy smokes. I could stay out with a combination, but the evening gives me the opportunity to do my job and do the 3-hour drive.
Okay, and this evening.
Yeah, I would agree with evening hours. I think it's helpful to not have to interrupt your day's process. And also, preference for nights, I would request not Mondays, but that's just.
And not Fridays.
I don't care.
Not Fridays.
Wednesdays are my day off, so I can do either one, but I think it works best for most people to be able to come after work, and I'm fine with 6 to 8. 6 to 10 would be a little tough, because I do have work the next day.
So we'll stick with 6. We'll look at the agenda. Tom, we'll talk to you about how much work your team has to do before the next meeting, because I want to have a next iteration before we meet again and have at least a few days for the team to look over some of the changes that we come up with. We need to work on those agenda items, and people need some time to get the presentations ready. So maybe 3 weeks. What is today, the 15th or something, right? Maybe the first week in February, Wednesday evening.
I have a request too. I think you guys are working toward this, but it really helps me to have things to review more, in advance. Like maybe a week would be great, but at least a weekend before.
Mm-hmm.
If you guys have things that we as the advisory committee need, and the public want to review. So that could be a goal.
Okay. And just to forecast where we are with our we paid the U of A College of Public Health to do some research in this area around outcomes and so forth with their maternal and child health unit, and that is due early March, first week or so in March. So that maybe one of those future meetings in early March will have an opportunity to have a presentation. And at that time, we could talk about whether we want to all go down to Tucson or what we want to do. But thanks for your participation. So you'll get an electronic notice probably the first week in February, evening meeting, 2.5 hours, maybe 2.5, just because we can plan for that.
We're hitting real strong the big three, but there's a lot of other things in the rules and regs that I would love to see addressed. Medications being #1 top priority. There were changes that were made that weren't even brought up today that were out of control. So I would love to have some other things in our rules and regs that other than the big three. So just putting that out there. More to talk.
Okay.
And I really want to thank you, Director Humboldt, for everything.
Oh, thank you. Thank you for your participation. Yeah. Have a nice evening. Drive safely in the cold.